Good morning, everyone. As we wait for folks to sign on this morning, and we'll start right at 10, you can sign in to today's event by visiting the QR code on the screen as it rotates through, or we'll be putting the link in the chat box. We just need to know who you are and with what organization you're with and your email. And that way we can follow up with you with the evaluation afterwards. Well, welcome everybody. Before we just jump right in, I do want to make sure everyone is aware that we are recording today's session and we'll make it available through the Asthma 411 website and the Center for Children's Health.org website. With that, you'll probably see a little recording note in the top of your screen. We do ask that you stay muted unless we open the dialogue up for a group conversation later. You can always type your questions in the chat box because we'll be monitoring that along the way. And I know Dr. Scott and Misty would welcome any questions you guys have. With the session being recorded today, please do just keep in mind that if you participate in an identifiable way, you acknowledge that your image or name will be recorded and are authorizing the use of your information in the recording as described. So we will post it online, which means if you speak or show your picture, other people will see it. So just be aware of that. And you can also turn off your video or participate in a different way if you wish to remain anonymous. So we'll welcome you all now on behalf of the Asthma 411 initiative, and we're glad you all took time out of your President's Day to be with us here today. I am Courtney Bernard. I'm with the Center for Children's Health at Cook Children's, and we are happy to be a partner on the Asthma 411 Consortium, along with Safer Care Texas and UNT Health Science Center, the JPS Health Network and Acclaimed Physician Group, and all of you within Tarrant County School Districts who implement Asthma 411 within your campuses. Our goal for today is to provide some timely and relevant continuing education for the school health staff who participate in Asthma 411. And so today we'll have Dr. Philip Scott and Misty Van Kampen give a case presentation on exercise-induced asthma. And then Leslie Alsup with Safer Care Texas, you all know her, she will give an update on the Asthma 411 program and share a couple of exciting things coming down the pike. So a couple housekeeping details here. We do want to make sure everyone had the chance to sign in. So Marquita's been adding the link in the chat and she will continue to do so. So you do that. This is how we follow up with you after today's session. It's how we know you came today. It's how you'll get your CE in your email box, your CE credit, and how we'll ask for your input and feedback through the evaluation afterwards. So please make sure you sign in. As I mentioned, after the session today, everyone who signed in will get an email with the link to the evaluation. You must complete the evaluation to receive the 1 hour of nursing continuing education credits, but we do welcome all feedback from everyone, even if you don't need a credit. We'll also, at the end of our session, before we log off, we'll have a raffle drawing that Marquita and Rebecca have put together for us. So we've got $25 gift cards and goodie bags as a thank you for all of you who were able to join us live today. So with that, I'll go ahead and introduce our speakers and we'll get going with our education. Dr. Philip Scott is a hospitalist with Cook Children's Medical Center. He is also serves on the Asthma 411 Medical Advisory Committee and has presented for our in-services before, so you might see a familiar face here. And Misty Van Kampen is the Director of District Health Services with Crowley ISD. So she brings that school campus knowledge here as well. So they're going to present a case presentation on the exercise-induced asthma, and will walk us through an application of the Asthma 411 Standard Delegation Order algorithm. So we'll get to see that in practice. And Dr. Scott and Misty have also allowed time for Q&A after their presentation. So as I said, please put your questions in the chat and we'll be monitoring that so that they can answer your questions along the way. So with that, I am going to hand it over to Dr. Scott and Misty.
All right, thanks, Courtney. I appreciate it. And thanks. I want to say thanks to Misty for helping me with this presentation. We got to
Uh-oh, Dr. Scott.
That time was kind of sandwiched between her being a school nurse. Oh, okay.
Uh-oh.
Let's see.
Yeah, you're good now.
Can you hear me now?
Yeah.
Okay.
Just don't move, right? Just
don't
right
move.
there.
Okay. I'll hold it. That might be hard for me. So yes, I wanted to say thank you to Misty for joining me for this presentation. We got to work together at Cook, and the time that we spent together at Cook was sandwiched by her being a school nurse before she came to Cook, and now has gone back to being a school nurse and is in leadership doing that. And so she has a lot of experience. So thank you, Misty, for helping me with this. And thank you to all of you school nurses. It's been a rough couple of years, I know, for you guys with the pandemic. And so thank you for your hard work and persistence in taking care of the children in our community. And COVID numbers are going down, at least in the hospital. The numbers that we're seeing are going down. I think everyone is probably kind of feeling a little bit of reprieve, but press on. Yeah, so can we move on to the next slides here? So today we are going to do, there's 3 objectives we have. One is identifying signs and symptoms of respiratory distress and asthma. That's always an important thing to talk about. There's subtle symptoms that are important to discuss. Then we're going to go through the Asthma 411 Standing Delegation Order algorithm as a case study. It's a good way to go through and learn how to actually use the algorithm. Hopefully the algorithm has been sent out to you. If it hasn't been sent out to you yet, you should look for that. It's very helpful, and we'll talk more about that. And then one of the things that's used in the algorithm is pulse oximetry technology. I know you'll have that in in most of your offices. And so I want us to kind of take a deep dive into talking about what is pulse oximetry, what's it measuring, and what does low pulse ox readings or hypoxemia mean in a patient with asthma. So, all right, without further ado, let's go to the next slide. So this is the algorithm. This is what it looks like. Okay, so you should have a file sent to you, or there should be some sort of link where you can get to this. It's very small on the screen. The purpose of the screen is not for you to be able to read everything. I just want you to know generally kind of what it looks like. There's green boxes, red boxes. This was created by the Asthma 411 medical committee, and a lot of thought was put into the specific numbers and kind of workflow in this. A lot of work has been put into this. This is for you guys to be actually helpful for y'all. as a hospitalist, we have all sorts of algorithms hanging on our walls in our office. Like, this is what we use and this is what we go to kind of help simplify the process, because you're dealing with a sick kid. Sometimes you get a little frazzled. It's good to have just a reference close by there. And you will notice that in certain portions, there's comments about follow certain district policies. So there's some things that are going to be unique to your district. And so you may even want to print this out and like make notes on it for your specific district. Okay, so use this as a helpful tool for yourself when you're seeing these kids. All right, next. And the best way I know how to teach is probably with a case presentation. It's fascinating. It helps it helps work us through exactly how we would take care of a patient when they're coming into or a student that's coming into our office. And so we're going to start with this case presentation. So you have a 7-year-old boy brought to your office by a teacher because he started coughing uncontrollably while playing soccer during recess. Y'all have probably, if you've been a school nurse for any length of time, this has happened, right? One of the triggers for asthma is exercise. And not all kids will have overt wheezing when they're having an asthma attack. A lot of times it's just coughing. Sometimes they'll even throw up. They'll get to coughing so much they'll throw up, and so they'll actually get brought to your office for vomiting. And so you have to be cautious about not missing some of the subtleties here. But they were playing soccer, got to coughing, just couldn't stop. And they recently moved to the area, and there's no asthma history listed in y'all's records. I'm sure this happens to y'all all the time too. There's no history of asthma necessarily listed for the patient, and so that makes it a little bit more tricky. But yeah, this is what was showing up in your office. And so again, I'm a pediatric hospitalist. I'm taking care of these kids in the hospital after they've already kind of come through the ER. But Misty, you have experience with seeing these kids showing up in your office for the first time. Can you give us an example? What's the next step that you and your nurses would do taking care of the student? If we can go to the next slide for that.
Well, we would do a physical assessment. We would call the parent. In that physical assessment, we'd also check their pulse ox to see what they're reading. You know, that helps us determine their heart rate and their oxygen saturation. So we get their vitals, listen to their lungs, look at their work of breathing. That's all done in that physical assessment, and we would call the parents. Kind of almost simultaneously, like when you see a kid come in and you see that they're having, depending on the level of distress that they're in, you know, is kind of what you would do first. That's what we would do in that scenario.
Perfect. Yeah, and we talked about this. When we were initially going through this case, y'all had just had a patient or just had a student come in the day before we were talking about this, and it's the exact same scenario. No family history or no history listed of asthma. Y'all had to call the family. The mom said, "Oh yeah, he does in fact have asthma."
Yes.
And so getting that piece of information is really important. That you can see here in the first part of the algorithm, we have where student presents with respiratory distress. We're doing that physical assessment, and then whether or not they have a history of asthma listed is kind of depends on where down the algorithm you go. So if they have asthma history listed, or they have their asthma action plan, that's straightforward. If they don't have that, then oftentimes getting a hold of the parent is helpful, because they can say, "Oh yeah, well they've been diagnosed with asthma in the past, but they haven't had any problems with asthma in a long time," and so they just don't list it as a history when they're registering for school in a new place. But they may have moved in with an aunt or uncle that smokes, and so they have new triggers, and so boom, we have escalating symptoms in this new place that they're in. And so there may be a history there. You just gotta dig in and get that information. All right, can we go to the next slide, please? So this is our this is our physical assessment. Just like what Misty was saying, we get a heart rate 132. That's on the high side for this kid. Respiratory rate 38, on the high side. Pulse SpO2 or pulse oximetry reading 92%. Temperature 98.7. On your lung exam, you see belly breathing. There's subcostal retractions. They have expiratory wheezing in the superior lung fields, and then diminished breath sounds at the lung bases. And I want to point out there that, you know, oftentimes you may listen to a kid with asthma and you don't hear any wheezing and you think, oh, okay, well, that's good. Sometimes they're just diminished. You can't hear anything, and that's bad. That's worse than wheezing. Okay, so if you hear diminished breath sounds, that's even more concerning, especially if they're really working hard to breathe. But you may hear wheezing in the lung fields and the upper lung fields, and diminished breath sounds kind of in the lower lung fields. And then a lot of times kids with asthma, they'll have eczema. And so if you look at their arms, you may see the front side of their arms is really dry, scaly skin. That's eczema. And a lot of times that accompanies asthma. So, all right, next slide, please. All right. So we have our next step of our algorithm here. Our pulse ox reading is less, or is 92%. I put it right on the fence just to prove this is, you know, you're going to have patients that are right on the fence. Okay, so pulse ox reading is 92%. So based on our algorithm, you know, if our patient in this case, do we have symptoms? Yes, there's symptoms of respiratory distress. Our pulse ox is 92%. And so we go over to 92%. So we're going to give 2 puffs of albuterol with a meter dose inhaler and spacer. And then you'll reassess in 10 minutes.
And I think that's an important part, Dr. Scott, if you don't mind me interrupting, just because a lot of times, you know, these kids will rebound just like we see them do in the hospital. And it's important that we, especially when they're borderline at 92%, that we reassess them in 10 minutes and make sure that, you know, that the improvement that we see immediately is sustainable and continues, you know.
Exactly. And it takes some time for albuterol to work too. Sometimes these kids, you'll do a breathing treatment and their oxygen levels will actually dip as you're doing the treatment. And that's okay. You give it time to start working. And that's the value of that 10 minutes. It lets time for the medicine to start working, to actually see the effect of that medicine. Now, in a case of a student whose pulse ox reading is less than 92%, that kiddo is pretty sick. They're sick, and we're going to go into explaining at the end here what that less than 92% means. But those kids, you're also going to give them albuterol. Okay, they get their albuterol treatments. But in this case, you're really going to need to get a hold of the parents and let them know they need to come pick their child up. And depending on how bad they look, if they're really in a lot of distress, y'all are really concerned about them, you may need to call EMS. But again, don't hold off on albuterol. They still need albuterol. It's just there's more things that need to happen. And so Misty, would you kind of speak to, I know in this algorithm we have 2 puffs of a meter dose inhaler and an inhaler. What about the nebulized treatments? And I think that's district to district may have little different recommendations. So can you speak to kind of what y'all do? And is that a district policy that y'all are going by?
Well, just depending on the student. For instance, I'll tell you, I have a student here in that comes to this campus where I'm at, the CTE, and her inhalers, sometimes that's just not enough. And she'll require, after she's done her inhaler, if she's still having trouble, she'll come to us because she's a high school, she's over on the college side. So she will come in the office and we'll administer albuterol treatments to her. And we do still do that. We have we are fortunate at most of our campus to have an additional room available that we can do that in, so that we can do it just in case that their asthma is brought on by COVID symptoms, they have other symptoms. That way we can spray those, we can let those rooms rest, and then we can decontaminate those rooms, sanitize those rooms, spray them down, whatever we need to do to make that happen. So we are able to do that at our campuses for the most part.
Perfect. Yeah, and I think that's a district and maybe even school specific situation. So again, that's one of those things that you have to kind of know what your district does, and even maybe have a note on your algorithm of what you're supposed to do or what you're supposed to use. But yeah, that's different district specific, whether you're going to use the meter dose inhaler or a nebulized treatment. And that's kind of been brought on by the pandemic. Okay, next slide. All right. So you administer 2 puffs of albuterol with a meter dose inhaler, reassess the student in 10 minutes. And on your repeat physical assessment, the heart rate's 120 beats per minute. So that's come down some. Your respiratory rate is 26 breaths per minute, which is improved. Your pulse ox reading is 95%. And wheezing and retractions are resolved. So you save the patient, they're fixed, okay? And in this case, our algorithm, if your symptoms have improved and your pulse ox reading is 95% or greater, then and obviously in this algorithm there's no risk factors for COVID, like they're not spiking fevers, those sorts of things. Then they actually can go back to class, and you have to, there's all the documentation you have to do later on. But I do want to kind of point out here, if they're not better, if their pulse ox reading is less than 95, you can do another treatment. Don't hold back on treatments. You can do another 2 puffs with the meter dose inhaler, and then this says reassess again in 20 minutes later. But yeah, this is next stage of the algorithm. It allows for more than just 1 puff or one treatment. Okay, and next slide, please. Perfect. And so this is kind of a continuation of that. Algorithm allows for a repeat albuterol treatment. If their saturations are less than 95% still after that second treatment, you'll see that on the left here, symptoms are not fully resolved. Their pulse ox readings are still on the lower side. That's when you're again needing to call parents to get them to either urgent care, get them to the pediatrician, because they probably need some oral steroids and continued aggressive albuterol treatments. And so that patient needs to go home. But a patient whose SATs are 95% or greater, they're doing okay. That's safe for them to go back to class. And so perfect. And so that's kind of this case. Can you go to the next slide, please? This is the hard part in my mind, because this is something that I don't do, right? This is y'all's thing. Y'all have regulations from the state, y'all have regulations from the district, all this documentation that y'all have to do. Misty's smiling because she knows there's all these things that have to happen, right? So God bless y'all for all that you have to do with these documentation, but this is kind of a follow-up box of what all needs to happen. So, parents need to have there's actually a document that you can send home with the student to give to their parents, that to let them know that their child received albuterol. If the patient or the student doesn't have a primary care provider, there's a referral list of different pediatricians in the area that you can refer them to. There's district and state policies that y'all have to document to submit that an albuterol treatment has been given. And all of these resources, you can go to the asthma401.org resources, and you can get all these documents to use. And so you may want to have those printed out, like actually in a folder. You could just have this link readily available. But there's those resources are available. Misty, any comments that you would have here, or any other details in your experience with doing follow-up?
I will just say that Asthma 411 they've really helped us to make this as seamless as possible. There is a lot of requirements with the documentation, especially when when you have to think about when our nurses are seeing. I was working in the clinics because I had so many staff out, and we're seeing upwards of 70 to 80 kids come through the clinic a day during the peak of COVID. And then we're trying to remember to do, so it's easier. I love the asthma visit report to the parent and guardian that can also serve as the note to the physician, to the medical home. I think what gets more onerous is, having to remember to go and document. And what we've struggled with is that documentation to the state as well, is you feel like you're having to document in so many different places. It just seems to make something that is supposed to help, patients and help students just a little bit more difficult, which is the way it is, and I understand the whys behind why we're doing what we're doing. Just wish there was a better way to streamline everything if we could, but it is what it is. I mean, but I will say this, my nurses and even when I've used it, the resource list, all of our document, all of the written notifications that you guys, the 24-hour follow-up check, all of these different things have been great tools for us to be able to utilize with our students. And so thank you so much for all you guys have put together.
Great. Yeah. Every job has their busy work, and this is the busy work, right? Yeah, that's just part of it. All right. Next slide, please. All right. So now is the pathophysiology part of this. This is the fun part for me. So this is a chance to talk a little bit about what is pulse oximetry. I know a lot of y'all are school nurses, but some of you don't have a nursing degree, and so I want to make sure that we take some time to talk about a little bit about, I know what a pulse oximeter is and how to make it work, but let's talk about some of the pathophysiology. What is it actually telling us? What information is it actually giving us? And so you can see on these pictures on the left, we have this is hemoglobin molecules. Hemoglobin is the purple part is protein, and that holds these the kind of four corners. There's the red dot in the four corners. Those are heme, and that's what binds oxygen, okay? And hemoglobin is a pretty amazing molecule. This is what fills up your red blood cells, and this is actually what makes red blood cells red, okay, when they have oxygen attached to them. But if you have hemoglobin that doesn't have oxygen attached to it, it is kind of a purplish or dark blue color. And then as you add oxygen molecules, you can see in the middle picture here, there's an oxygen molecule attached on the left side. That side has started to turn red. And each subsequent oxygen molecule that you add turns it more and more red, okay? And so, and that change actually changes the color of the hemoglobin, right? And so this is why when venous blood is kind of bluish sort of colored, and then arterial blood, pulse oximetry technology takes advantage of this color difference. And basically it just shines a light through the skin, and it looks at the pulsating blood in the arteries, and it looks at what percentage of those hemoglobin have oxygen attached to them. So if you have an oxygen saturation of 95%, that means 95% of your hemoglobin have oxygen molecules attached to them. That's good. That's a lot, right? And that's literally what that number means. The number that pulse ox machine is giving you is the percentage of hemoglobin that has oxygen attached to it in the arteries, the arterial blood. Okay, and so that's what your pulse ox is measuring. And what does that mean for asthma? Let's go to the next slide and talk about what does that specifically mean for asthma. This is a complex diagram. We're going to go through it step by step here. Okay, don't let your eyes glaze over here. Don't let me lose you. Okay, but basically this is telling us what's happening in asthma. Why are our pulse ox readings low in asthma? Okay, for two reasons. One is low VQ, and the other is physiologic shunt. Okay, these are the two things that are happening in asthma that cause low oxygen readings. Now I want to talk about a couple of the abbreviations here. Okay, PaO2, you can see on the right, is partial pressure of oxygen. Partial pressure of oxygen is a measure of, it's a calculation based on what is the atmospheric pressure and what's the percentage of oxygen in the air. 80 is normal. Okay, so you can see on the left side of these airways, the PaO2 of 80, that's normal. Okay, and the green bubbles here, those are your alveoli. Okay, so this is the functional unit of the lung. Okay, this is where all the good stuff happens. This is where oxygen exchange happens. This is where oxygen goes from the alveoli, from the lung, into the blood, and CO2 goes from the blood into the lungs to be breathed out. Okay, PA, the PA, capital P, capital A, that's pulmonary artery. That's blood coming from the heart that's deoxygenated to pick up oxygen. And the PV is pulmonary vein. That's blood that should be oxygenated going back to the heart to be pumped to the rest of the body. Okay, and so the first diagram on the left, you'll notice it says low VQ. V means ventilation. Ventilation is we're breathing air in and out. We're ventilating. Okay, so that's ventilation. Q means perfusion. That's blood flow. You know, your veins are perfused, or your arteries are perfused with blood. Okay, so if you have a low VQ, that means your ventilation is low. And notice here on the left box, there's bronchospasm. Okay, you'll notice that the bronchiole on the right is more narrow than the bronchiole on the left. Okay, air is not moving in and out to that right alveoli, and so you'll notice, what is the PaO2 in that right alveoli? The PaO2 is 30. Okay, because what's happening is the blood has picked up all the oxygen and carried away, and there's not enough ventilation. There's not enough air moving into that alveoli to replace the oxygen that's been picked up. Okay, and so the PaO2 is lower, and you'll notice that the blue blood that's passing by the alveoli that has a PaO2 of 80, that picks up lots of oxygen. It turns the blood red and it goes to the pulmonary vein. You'll notice that the alveoli on the right, it has it picks up just a very little amount of oxygen, and so it's more of a kind of a pinkish color returning. And so that blood in the pulmonary vein, it's a mixture of blood that's oxygenated and blood that's not oxygenated, and so you have a lower pulse ox reading when that blood returns to the heart. Okay, and then that blood gets pumped to the rest of the body, and you're measuring it in the finger, what percentage of hemoglobin has oxygen in it. Okay, there's a more severe form of this called the physiologic shunt, and that's the box on the right. Okay, you'll notice in the box on the right there's a mucus plug, and that the alveoli on the right, it has no flow whatsoever. That mucus plug is completely plugging that alveoli. So the PaO2 in the right alveoli and the right box is 0. It's picking up 0 oxygen. Okay, and so that's why that capillary that's adjacent to that alveoli on the right it stays blue. It doesn't pick up any oxygen. Okay, and that deoxygenated blood then mixes with the oxygenated blood. And so you have a lower pulse ox reading, okay? Now this is happening in a microscopic level all over the lungs. There's little patches here and there everywhere where there's more bronchospasm in other places and mucus plugging. And so if you are getting a lower pulse ox reading, that means you have more VQ mismatch or low VQ and more mucus plugging. And so the lower your pulse ox reading, the more severe our bronchospasm is, the more severe our mucus plugging is. And that's why these kids that have lower pulse ox readings, we have to be concerned that, okay, this is a more severe disease course. They're further along in this process. And what does albuterol do? It opens up, it dilates those bronchospasms. And so that's literally what you're doing. When you're watching the pulse ox reading come back up, you're literally watching those the bronchospasm resolve, and you're watching that air basically move into those lungs better. And so that's the beauty of albuterol. And so this is your nauseating physiology lesson for the day. Okay, y'all may have to watch this again because it can be a little bit tricky, but this is a great, believe it or not, this is a very simple version of this diagram, and it's very helpful to understand what's actually happening in the lungs with asthma, and what is your pulse ox measuring. And I do want to also put in a comment here that and Misty commented on this very well. You have to take the full picture. When you're doing a physical assessment, your pulse ox reading is just one measure, okay? If your pulse ox reading is not too bad, but you have a kid that's really working hard to breathe and has obvious retractions, that's still bad, okay? The pulse ox is just one more parameter that you can use to help make decisions for patients. And I know the algorithm really kind of focuses on pulse ox, but please hear me say, look at the full patient, look at how they're breathing, the work of their breathing. Don't just rely on that pulse ox number. It's a helpful tool, but it's not the only tool that you have, okay? And that's it. We do have time for questions. And I know y'all are shy about asking questions, but please, we welcome questions. We welcome any comments or insights that you guys have. And Misty, I welcome any comments that you have, or any other thoughts that you have that would be good to pass along. We can go to the next slide too, I think.
Dr. Scott, can you remind us of what a normal reading is, pulse ox reading is?
Yeah, so we're at close to sea level, right? So if you were in Colorado, you would have, that's a different answer, right? Because it's the air is thinner, so your oxygen levels are lower. But for the most part, I mean, in this algorithm, essentially 95% and above is normal, okay? And most of us probably are sitting at higher than that. We're probably closer to 96 to 100%, but technically 95% and above is higher, is normal. That would be normal. Yeah. Good question. Thank you for pointing that out.
Is this the slide you wanted, or would you like to show your references?
Yeah, no, this is just I think this is the final. This is just recapping our objectives. Yeah, so we talked about signs and symptoms of respiratory distress already. Maybe the other comments, the subtleties is nasal flaring. I don't know if you've ever seen a kid have nasal flaring. You have to really stop and look to pay attention, but some kids, they'll have nasal flaring when they're in distress. We talked about retractions. We talked about wheezing. We talked about diminished breath sounds. We talked about vomiting. The case that Misty and I had talked about a couple of weeks ago was the kid actually presented with vomiting was one of the symptoms he had. And then the other was sleepy. Sometimes these kids are they're just tired. They're worn out from all the hard work they're doing breathing. And so teachers will say, they're just falling asleep in class. And so get a good listen to their lungs. Consider respiratory distress as causing that. We talked about the algorithm. Print that out, make notes on it, use it. That's for you guys. That's a tool for y'all. And I think I'm excited about it. I think it's a great resource to be able to have. And then understand pulse oximetry. Know what it's telling you. Specifically, pulse oximetry isn't necessarily measuring your lung function. I mean, in asthma, it tells us that our lungs are not working well, but what it's actually measuring is what percentage of hemoglobin has oxygen attached to it. So that's the kind of critical piece. But let's see, and that's it for me. Any other?
All right, well, we've got some great, well, I'll go ahead and go to the next slide. I see questions coming in the chat box, so we will definitely get to those. That's excellent. But here are the references you guys included.
Yeah.
Okay. Okay, well then if you're okay, Dr. Scott and Misty, I'm gonna go ahead and stop screen sharing this presentation and we can have a conversation with some of these questions.
Liz commented in here, chest, stomach, or back pain. And that's a good, you know, a lot of times these kids will they won't understand that maybe they feel this all the time, right? This is kind of a normal thing for them. So the only symptom they may have is that their stomach hurts from breathing so hard, using their muscles, their diaphragm. Maybe it's their chest or their back that hurts. So that's a good point, Liz. Thank you for sharing that.
Yeah, and Liz is our asthma educator. So that was that's a very important question from a very important person. Yes, thank you, Liz. That's good. Yeah, and Missy, I like the point you made about was having wheezing, was hypoxic, and I asked the mom, how often do you cough with exercise, or how often does she cough?
Oh.
Oh God, you are freezing up. Can you repeat
Coughing
that?
with exercise every day is not normal. Oh, yeah. Can y'all hear me now?
Yes.
Yeah. So I'll stop moving again. So I admitted a kid this weekend who was admitted for hypoxia. She was on oxygen. She was before, and I asked her, do you cough? How often does she cough with exercise? And mom said, oh, she coughs with exercise every day. I just thought that was normal for her, and that's not normal. And I want y'all to hear this. These subtle things. A lot of times people, they're just used to having asthma symptoms all the time, and they just don't know that it's not normal. So it's important to ask these questions. Are they waking up coughing at night? Are they coughing with exercise? Because these are triggers or red flags to say, this is asthma. They need to talk to their pediatrician about this and get on the right medicines. Because if y'all can catch it early, then I'm not catching it while they're hospitalized. It's better. The earlier, the better. The earlier, the better. And we got some other good questions here. Let's see.
Uh-oh, he's glitching out again, Dr. Scott. No.
Who's the best person to answer that question?
Dr. Scott, you cut out again, so let's repeat the question. I thank you for reading the chat box for us.
Yeah, I think the first question is, where do you document for the state? I don't know who the best person is to answer that.
Misty, you addressed that, and Leslie did too.
Person? Yeah,
want to
we
speak
addressed
to that?
Yes.
But just to go over it in case someone's not looking at the chat, just as Misty has the link there, and the quick reference guide that we put together has a link to that as well. The important thing is to know your district's policy. Most of the districts are asking people individually every time they provide a usage of those standing delegation orders to enter it into the DSHS website directly. But not all districts. Some districts have some administrative support and are doing that. So please do know your district's policy on that. And Misty, thank you for so quickly putting the link up there for us.
There's another question here from Angela Clark. So this is kind of shifting gears a little bit, but she asks, any thoughts on when we should ask parents to go to urgent care versus the ER?
Good question. They can give steroids in both places, and they can give aggressive albuterol treatments in both places. So maybe the closest place is the best option, because the sooner you can get them to where they need to go, the better. If EMS is picking them up, they probably should go to the emergency room. If the parent is picking them up, then I think it's reasonable for them to go to urgent care. That would be I think that would be my thought process, because we want to avoid sending too many kids to the ER. Urgent care can address a lot of these kids' needs. But the other thought is, if you have a student that gets real sick real fast and always ends up getting admitted to the hospital, it may be worthwhile just sending them to the ER too. So some of it's just knowing student. I
know Dr. Scott is frozen, and I just want to say a couple of things. I know, being aware as well, as I've spoken to many of you over time, there are families who may be really challenged to get to the urgent care. And I think that's something that's also, a consideration. I know folks who have said, well, the parent tells you they're going to have to walk to school because they don't have a car. Clearly be aware of those social factors that may also impact. Something that we're working on building into our CEU is also that risk stratification for these patients, and what are some of those risk factors for a really severe adverse event. And just as Dr. Scott was saying, if a child's been hospitalized in the past year, or especially if more than once, so those are all those considerations. And then I'd love to hear, I'll stop. I know Dr. Scott, we need his expertise as well as Misty and others of you who are there on the front lines.
Agreed. Yeah, concerning social factors is important in making that decision.
I know that in Crowley, we, I urge, and I see it as a good way. I was actually talking to one of my staff this morning about, if we don't have a primary doctor and this kid needs to be seen, we have our telehealth that we could get the student seen, especially if maybe they've moved here, they're new to the area. And then we, of course, would refer them on to, a medical home. That's what's so important that these kids, and that's the big push with everything through Asthma 411, is to make sure that these students are being followed up by their medical home, because a lot of them are running out of their preventative medications, or even their maintenance drugs, the things that their albuterol. We have kids that we'll see more often than others for Asthma 411, and just connecting with those families, connecting with that physician that they've listed on our records, and making sure they're plugged into that medical home. I think that's a big piece, because I don't know what you guys have seen out there, but what we've noticed here is a detachment from the medical home since COVID. There was a long break of kids going to their physician for any of their wellness checks or anything like that. And we've got this gap that's happened, and we need to help try to fill that gap, try to reunite them with their medical home, and, and make a way for, help assist those families however we can. Whether it's knowledge that Medicaid transportation exists for them, or whether it's, whatever it is that we need to do.
Thank you, Misty. I'll piggyback. There's been, we've heard this a lot through Asthma 411 and from the schools in general, but really, you mentioned earlier talking about the streamlined communication, making sure you have the tools you need to do that follow-up, make that follow-up easier while doing your all that kind of paperwork. But I'm wondering, with that, and then bridging to what you just mentioned with the medical home and trying to keep the family and yourselves connected with the PCP, making sure you have an asthma action plan on hand, making sure you've got the medical, this may not be what it's called, the medical authorization form. Is that what it's called? Okay, right, to allow the schools to administer the medications that the kiddos need. I'm wondering if you, Misty, or anyone, any of our school health staff on the call has some strategies to share, or how they've streamlined their own communication processes, or have had success with their families in getting those things in place.
Well, I think this is Rebecca from Northwest, and we're going to get a chance to kind of go over our program in a minute, but we were able to take, we did the mini challenge, and we were able to get some resources from Asthma 411. And so we are taking that to make a program to follow up with these families. So I don't know if Leslie wants me to go over that now, or just wait until she does her part of her presentation.
I can
wait.
Yeah, wait a little bit. And Asthma 411 mini challenge, we're excited about that, and we can't wait till a little later. I'll just say it was difficult during the pandemic, we know, to get this started, but this is just a first pilot of it, and we can't wait, Rebecca, to hear more about it. And I'm so excited about what you're doing.
Thank you, Rebecca. Yeah, we want to celebrate that with you and hear all about that.
I have a question. Working with the Healthy Homes Asthma Program, we have come across some families who are unaware of the medical authorization to return to the school nurse. Is there a way that we can encourage our nurses to communicate with the primary care doctors to make sure that the children have those forms? Or does someone on the call have a reasonable way to do that, way to inform the parents? Because a lot of the parents aren't really familiar with the form. And so we've run across that with our program, and want to make sure that on our side, we're giving them the information they need, but we want to also make sure that they have the medication and all of the paperwork that they need.
I know that for us, in Crowley ISD, we've embedded it in our and we've made it a required field more recently, but we've embedded in our enrollment process. So it's a form. It's actually a form they have to fill out, and it's a piece that they have to actually complete before they can move on to the next piece. So and it's a yes or no, opt in or opt out kind of thing. So, so that's how we've done with the EpiPen and with Asthma 411.
Thank you.
Misty, do you find, sorry, I'm going to put you on the spot again. Do you find that families understand what that form is and that they're filling it out and opting in, or do you still have some?
Of course, well, and that's why we're making that a requirement, because what I've found for the years in the past, it's just blank, and it'll be blank for several years, for as long as we've done Asthma 411, it's blank, blank, blank. And then a lot of people, while more than half of our districts utilize it, there's a good portion, probably a quarter or maybe a third, that weren't utilizing, saying yes or no, to those questions. So yes, I was thinking about that. It's funny you asked me that, Courtney, because I was just thinking of that as they were talking. I was thinking, we probably would behoove us to send out some information at the end of the year, in beginning of this next school year, just saying, hey, this is a program we have. You have the ability to opt in at enrollment, but if you don't, you could fill out this paperwork or whatever, and we could give them a medication authorization form to fill out, after enrollment, so that we could capture some of those that we didn't get in the first. But yes, and explaining and I was even thinking, what about a public service announcement on your webpage, and that would just kind of go out right before school of, hey, did you know that, and some asthma facts, and then this is what your school has to offer for the students. We just want to make you aware and direct them to the Asthma 411 resources and the webpage and all of that too. I think that would be great as well.
I think those are fabulous ideas. And I'll just say we'd be really happy. We know that there are some concepts at the end of the year of getting that sort of a back to school packet and getting parents thinking about that over the summer. And I think that's something, I can say we'd love to support with the districts, trying to make that more widely available. I know I want to kind of give a shout out with Cook Children's and Dr. Amin there. I know that they've also put what's called an integrated asthma action plan in their system. Now, I think having it there is a great first step. How it's being used, we have, especially during the pandemic, I'm not quite sure, but at least it does give on the asthma action plan a place where the parents can check off that the child has the permission. The physician right there can check off, yes, you have permission for the medication authorization form. And yes, the school nurse has permission to discuss the child's condition. We know even if the parent will say, yes, you can call the doctor or the healthcare provider, sometimes healthcare providers don't have that permission and they're worried about it. So this is one of those best practice, national recommendations. And we know that's hard to put in place. And boy, changing the medical records systems is like moving a mountain. So hats off to Cook Children's System for doing that. I think we can also consider knowing that that approach is so fantastic, Misty discussed, but in that kind of packet of information parents get after a breathing treatment, understanding delegation orders, that medication authorization is something that we can consider adding. And I think from a process perspective, we'll take some steps to do that. But I love that approach to the registration that we've talked about in the PSAs.
We've got another question in the chat from Michelle Davis. And Michelle, feel free to unmute to share a little bit more here. But what are the normal pulse and RR for kids 4 to 11? EMS told a parent after I called for respiratory distress that 130 was normal for a 4-year-old.
Yes, so you will, if you reference different references, you'll get slightly different answers for this, because it's dynamic as kids are getting older, right? So younger kids are going to have a faster heart rate. But what I would do is just get your reference that you use and use it, and have that be your normal. You have to, and so you can go to UpToDate, you can go to, whatever reference you want to use. And Asthma 411, actually in their training, they have a really nice chart of normal respiratory rate, heart rate values for kids. And so use that if you want to, but just know that if the kid just came in from playing outside, their respiratory rate and heart rate are also going to be faster, because it's supposed to be, because they were just out running around and playing. So all those vitals have to be interpreted in the context of what you're dealing with. But yeah, EMS they're going to probably be using their own reference guide. Just because it says on a reference guide that this respiratory rate is normal for this age, they're not looking at the kid. You're looking at the kid. So you have to interpret they have. But I would just use your reference and use that. Just know that EMS may be using slightly different ranges, and that's okay.
Okay, thank you. The kiddo actually was a 4-year-old that was in the foyer and was laying her head down. So she wasn't even a student of mine, but just watching her breathe when I walked up, because somebody said, Shelly, something's just not right. Can you come just up here and look? And she had retractions, she was flaring. I think her respiration rate was 55. I mean, everything, and her lungs sounded awful. So I called EMS, but I hate to say they were trying to poo-poo the situation, but that's kind of how I felt. They ended up transporting her to Cook's, and she came home that night, but she had 4 breathing treatments in the next hour and a half because the mom contacted me to let me know what had happened. So just one of those where it's like, I knew what I saw, but it was almost like they were trying to say, no, what you're seeing is normal. And I knew it wasn't. So
you did good. Stick to your guns. The thing you have to also think about is EMS, they are tired and worn out just like everybody else. And so they're giving pushback because this happens in medicine. This happens between ER doctors and hospitalists, right? Is they're trying to scramble to go see the most important patients that they need to see. But sometimes you have to be firm with your concerns. And so you did good. You did good.
If I should say, one thing, with this whole decision and kind of reinforcing that question of, the bottom line is your best assessment of what's safe for this child always. And when you have that question in your mind, it doesn't feel right. You're looking at all of those different points, the pulse ox, the breathing, the whole picture that Dr. Scott and others have mentioned, and go really what's safe for that child each time. We do have those references, a reference chart on the CEU. We're updating the CEU right now as far as some of the other documents, but the reference guide is there with the pulse and respiratory rate for all different ages, as well as those retractions and nasal flaring. So that's a reference, an update. I'm going to ask a quick question here and ask Dr. Scott. It ties to this. One of the questions that we get a lot is about exercise-induced bronchospasm. And it gets into that sense of asthma control. We have the asthma control test that we're always advocating, not in an emergency situation, but that asthma control test is really quick, down to 7 years old. They can complete it themselves. That can give you a sense of where this kiddo is. But there's also that rules of 2, where the kid is coming in more than twice a week to use that inhaler, whether it's asthma 411 or anything else. What's that question in your mind? That they may not just have that bronchospasm that the albuterol will help, but they may have that inflammation and mucus plug in there going on and need really more medicine. So the question I wanted to bring up, Dr. Scott, and is thinking about the exercise-induced bronchospasm, in that context of the rules of 2 that we so often will recommend to people. And kind of, nurses I know have asked us, and this is a great time to address, well, how does that really, those 2 pieces fit together?
Yeah, and so for a kid that we know has exercise-induced asthma, and the family's been educated on that, they're on a controller medicine. Sometimes those kids they'll come before recess or before PE to get their puffs of albuterol or their albuterol treatment. And that's okay to do it before. And you could do that every day before exercise. But what you're talking about is a kid that they go to recess and they have to be urgently brought in because they're coughing or having difficulty breathing and they need an urgent treatment. Yeah, so if that's happening more than or twice a week or more, that's a sign that their asthma is not controlled, and they need to be on a controller medicine if they're not already on that controller medicine. Or their controller medicine needs to be increased. If they're taking controller medicine and they're still having cough with exercise, they're having to come twice a week or more. And the other thing, and you won't assess this as parents, but twice, if they're waking up coughing at night, it's more than twice per month. So twice per week during the day, or waking up at night 2 times per month. Those are signs of poorly controlled asthma. Those are the early red flags that parents just are used to. That's just their normal life. And so those are the red flags. Send them to a pediatrician if they have those symptoms, and tell them to talk to their pediatrician. They need a controller medicine.
Thank you so much. I think that, context of what is the health care that child is receiving is so critical. And we know over-reliance on medications like albuterol is actually a risk factor for severe outcomes, including those rare but asthma fatalities happen. And we need to, I know everybody here contributes to keeping our children safe. And so thank you.
Well, thank you all. I think we were able to address all the questions in the chat box, which I'm excited for. Thanks for posing those questions and having some conversation with us. And many, many thanks to Dr. Scott and Misty for joining us today and putting this presentation together. That was really, really helpful, and a topic we haven't addressed yet as a consortium in our education. So we're really glad we were able to do that. I'm now going to hand it over to Leslie also. So Leslie, feel free to screen share to do that. And we'll get to circle back to Rebecca to hear more about what she's doing at Northwest ISD. But they'll walk us through some program updates.
Absolutely. Thank you so much, everyone. And I also want to take some time just for an enormous thank you. And we always start with this, and it's just such a wonderful collaboration. And I'm so grateful to the Cook Children's team that puts together these symposiums, to Dr. Scott for his expertise, and to everyone really who's involved. I think that the algorithm that Misty and Dr. Scott did such a great job with is a wonderful example of how people have pulled together, where, as Dr. Scott mentioned, you have the medical expertise of our 6 pediatrician advisory council, really assuring we're aligned with national guidelines. We had health service administrators give us very detailed feedback about the language to make sure it was aligned with school health, with the patient safety folks at Safer Care Texas working on the diagram of that algorithm and putting that together. And really it pulls, and of course you out there are participants today who are then taking care of these children. So thank you so much to everyone. I am going to go ahead and just have some spring updates that we're really excited about. And we'll touch on these briefly in the next couple of minutes, but we're going to start off. I have Rebecca Green, who is new to our staff, and I think you'll be hearing a lot more from her. Then we're going to ask Rebecca to talk a little more in detail about what they are doing and the concept of the Asthma 411 mini challenge, along with some of the virtual asthma self-management education and what we're doing at some of the policy issues that have been touched on today. So Rebecca, I would love to have Rebecca introduce herself.
Absolutely. So my name is Rebecca Green, and I am project coordinator with Asthma 411. I I was an outreach specialist at Catholic Charities of Fort Worth, and a lot of my work that I've done is really rooted in community outreach and community engagement. So that's really what I have been tasked to do in this new role. A couple of exciting updates is that our website is actually redesigned, and it should be kind of launching, I'm thinking, by the end of this week. So that will actually make a lot of our resources much easier for you to find. Hopefully, that was the whole idea of that. So there's also a place on our homepage currently for people to sign up for our newsletter that I am creating monthly. In the newsletter, we have resources really for all of our different audiences. I try to make sure that I have resources for children as well as parents, and then just kind of highlighting some of the community events that we participate in or that we are trying to kind of shed light on. Another thing really that we are trying to, as spring comes and hopefully COVID cases kind of continue to decrease, we're trying to get out into the community. So go to 2 community events once a month. So we really are trying to kind of increase our presence within the community and get all of those resources and education out there.
Wonderful. Thank you so much, Rebecca. The next thing I wanted to mention is talk a little bit about the Asthma 411 mini challenge. And we put this request for proposals out in the fall. And we know that it was a very difficult time to try and launch and pilot this with the pandemic. But our hope is that we know that the school nurses, our school health administrators and staff are doing such a phenomenal job with providing services. And yet we also know that it is such a struggle to have the resources and the time to implement all of these steps and all of these practices to connect children with resources and the many other elements that are ideal. And so we've put the mini challenge out there to try and provide districts with a small amount of additional resources so that they can then take that lead in innovating and finding solutions to how we can streamline and make this all work better. We are definitely planning on continuing this next year. So keep in mind, as Rebecca describes her program, that we will be hoping to do this in mind. So if you've got innovation in mind or an idea, please keep that in mind. We'll have another opportunity. Rebecca has provided the proposal from Northwest ISD, and we're so excited about that. And Rebecca, please give us that overview of what you all will be doing this spring.
Okay, thank you. So we, Dr. Scott and Misty both referred to this, and then everybody else who's commented has referred to this. The program itself, the Asthma 411 program, is so valuable to us, and the tools that are online are so valuable, but there is a breakdown between the student coming in, taking, using the inhaler in the clinic, and then getting them linked up with the resources after the visit. So sometimes we see somebody one time, we see somebody, the next person repeatedly over and over, and the nurses in the clinic just do not have time to figure out what happens to the student after they use the inhaler in the clinic. So we ask for some money to provide a nurse once a week who would follow up on these students and figure out what's going on with them. So we want to make sure that every student who uses the inhaler gets the follow-up treatment that he or she needs. And so the goals were to get the parents to the website and to the online material and resources. Sometimes it's just a challenge to make sure the parent understands that having that medication one time in the clinic doesn't cure asthma or cause it to go away, that it could be something that could get worse at home when they don't have access to medication. Sometimes the challenge is that they don't have access to a doctor, or they don't know, or they don't have insurance. So we want to make sure that we get them, we find out where the breakdown is. We want to make sure that every student ultimately gets an asthma action plan that includes an inhaler and a spacer, and that we in the clinic follow up and have a care plan for them so that we know how to treat them when they come in. And so we hired a nurse just 1 day a week at a sub rate, which we all know in this area is not very good. We were so lucky to get Rachel Rivera, who's on this call also. And so, so she came in with a huge amount of ideas of her own. So it's just kind of blossoming into this great thing. So we are here today working on, for the first day of the actual challenge she's compiled some resources along with Rebecca at the Asthma 411 program. We're starting to make phone calls to parents of the students who've had the Asthma 411 inhaler in the clinic, and just do that case management. And as Misty said, reuniting them maybe with a medical home, figuring out where that, how we can help them with that step.
Wonderful. Thank you so much, Rebecca, for that, and also for Rachel. And we're excited, and we look forward to you sharing your experience on the end of this, and how we can look for ways to make this sustainable, as well as to look for other opportunities that we will hope for next year to continue the Asthma 411 mini challenge. We also know that asthma self-management education is a critical complement of what kiddos and families need. And we know that healthcare providers are stressed to do this. It's, having this happen in the clinic is an enormous challenge. We know it's also a huge challenge while people say, wow, school nurses are in this great position to provide asthma education. Yes, indeed, but you've got so many stressors and so many other needs that you are trying to meet on an ongoing basis. We try to have some of those important asthma self-management education tools like refreshers on inhaler technique available, but providing comprehensive asthma self-management education remains a challenge. So we are trying to make this available online. And again, we're just going to pilot this. We're going to base the education online from contact with the American Lung Association. So we acknowledge their important contributions and well-established programs. We have 2 lead instructors here at Asthma 411 Services at Safer Care Texas at UNT Health Science Center, Tracy Champley and Bobby Breton. And they will be available to do the asthma education online. We are hoping we can identify students, perhaps those who have used the standing delegation orders, and provide sessions on comprehensive asthma self-management education virtually. We hope eventually to be able to do the whole 4-session for each of these programs. We know that with trying to move in the restrictions of the pandemic, it just may be 1 or 2 sessions that we can get out this spring. But we are reaching out to our school health administrators and offering this, see how we might be able to pilot it. And if anyone on the call has a special interest in having 1 or more students signed up, please let us know. Feel free to reach out to us. Another thing I want to let folks know, we had lots of comments today about the challenges of implementing the full requirements that are now mandated and the need to streamline that. And it's something we hear a great deal about. I hear a great deal from our school health staff. We know that the changes that came with 2019 and the legislation were a real departure from what Asthma 411 had done in the past in terms of some of the requirements. And while there's good things in terms of making sure we're doing the follow-up, other parts of it have been a big burden. I want to let you all know that there is just this last few months, a national policy that has come out about what those standing delegation orders and what the legislation should allow. And it is much more similar to what we were doing before the most recent Texas legislation was passed. All of these national groups signed off on it, including the National Association of School Nurses. Again, while we know it's important to be communicating to parents about the child's condition, whether it's asthma, how to respond, we also know that we still have too many kids who are experiencing respiratory distress at school and may not be identified in their school records as having asthma, for example. There is an effort that we are able to engage with to have a task force on considering what standing delegation order legislation should look like in our state. I will be participating in that. The Asthma 411 Medical Advisory Council will be participating, and I want to leave the door open that anybody, you have expertise, each person on this call that has worked with this standing delegation orders knows what the challenges are. And as Misty said, we are trying to do the right thing for students and the right thing for families, and it can be better than it currently is. As we go forward, we hope to have a forum on this. And again, I'll be letting health service administrators know, but I also invite anyone who wants to be involved in this process to let us know. We have, I think, an opportunity in our next legislative session to have legislation and rules that are more responsive to what the needs of children are and what will really work on a school campus. You all are the experts in that. So thank you so much. That's really what I had, and I will stop sharing my screen.
Excellent. Thank you so much, Leslie. And congratulations to Rebecca. We're excited to follow along with Northwest ISD to hear how your new program, your new efforts map out for your kiddos. I am going to, in our last couple minutes here, I'm going to invite Marquita to screen share or do what she needs to do because it's time for our raffle that Marquita and Rebecca have arranged for us. So Marquita, you want to take it over there?
Hello, everyone. Thank you all for joining us today. We just want to show a little appreciation and do a raffle. We actually have 10 goodie items. We have Asthma 411 was gracious enough to get us a Asthma 411 swag bag, and Cook Children's also will be providing gift cards. So we'll have 10 participants. So we'll get started. For our first Asthma 411 swag bag, we have Victoria. Thank you, Victoria. I'll be in touch with you as we get the finish the raffle. I'm sorry. The next one will be for an Amazon gift card. Carla Cochran. All right, Carla. I'll be in touch with you. All right, next we have another swag bag. Mary Kennergley. I hope I said that right. I will be in touch with you, Mary. All right, our next Amazon gift card. Jennifer Kuykendall. I hope I said that right. I will be in touch with you. All right. Next is another Asthma 411 swag bag. Julie Torrey. I'll be in touch with you, Julie. Our next Amazon gift card will go to Mallory Hensley. All right, thank you, Mallory, for joining us today. Our next gift will be Asthma 411 swag bag. Oh, Rebecca, I'll be in touch with you to get you your swag bag. Okay, our next one will be an Amazon gift card. Valerie Butler. Thank you, Valerie. I will be in touch. Okay, and it's our last asthma swag bag, Asthma 411 swag bag. Margaret, I got you, Margaret. I will be in touch with you. And our last raffle for today will be a last Amazon gift card. All right, Leslie Ammons. Thank you all for participating, and I will be in touch with you within the week.
That was super fun. That's just so exciting, and a little celebratory confetti every time. So that's wonderful. Well, okay, again, thank you all so much. Dr. Scott, Misty, Leslie, Rebecca Green, Rebecca at Northwest, for sharing everything you all did today. And I have to give a very, very well-deserved special thank you to Marquita Jones for planning and putting together this in-service. She did phenomenal. And then our team, Charles with Media Services, and Jean providing our CE, nursing CE. So it takes a village to put this kind of stuff together. I know you all know that. We appreciate it very much. Okay, so as a reminder, you all signed in, and so be checking your email in the coming days. You'll get an email from Jean in our education department with your evaluation. We would love to hear from everybody, but that evaluation is your key to getting your nursing CE. So make sure you complete the evaluation and follow the directions on the screen so you get your certificate. We want everyone to get credit. We'll also, with Charles' help here today, we've been recording this Zoom call, and so we'll be able to get that posted online in the coming weeks. That might take a little bit of time as it goes through all the different channels, but we will notify you when it's available on the Center for Children's Health.org website and asthma411.org website. So we will send that out, and we'll send out the slides and the algorithm again so that everyone gets that. But share with your friends. You'll be able to get a CE by watching the recording for a limited amount of time also. So there's still an opportunity there. But with that, thank you all again for joining us today, and we hope you have a great week.